Hello everyone, welcome back to Grow Med. So this is the part 2 video of the surgery revision, and in the part 1 video we have already discussed about this breast. So all the important things from the breast have been covered in that. Now be in this video we'll discuss mostly about the thyroid and all the important things related to the thyroid, the diseases which you must know. Okay, so this watch this video now and note down all the important things, and watch this video on a repeat and recall all the things, revise the things. क्या बोलते हैं मतलब रट लो सारी चीज़ों को. ठीक है, so you need to know all these things. I know now for now this PDF is like a quite lengthy, but it is must because you need to know all the important things, because like basic questions should not be missed. Basics तो गलत नहीं होने चाहिए एग्जाम पे. This is my main focus and main target. ठीक है, some difficult question comes, some randomly question coming from any other topic. If that gets wrong, it's okay, but the most frequently repeated topics, if those get wrong, that will be like uh, regret. So to avoid that one, my focus will be mostly on the frequently repeated topics from all the subjects. So thyroglossal cyst is a must do topic, frequently repeated. If you go and analyze the past year now, you can see one question from this in each of the paper, so it is a must do topic. And also as the exam will be near in the November or the December, I will provide to you another very compiled PDF for this, so that in very less time you will be easily you can recall all the things easily. Okay, that one I'll be providing in the November or December, which will help you in the last minute revisions. Right now, read using this PDF, or you can also use your notes. In your notes, if any point is missing from this one, you can add it to that, or you can just add that point to this. ठीक है, so notes पे इतना मतलब don't focus कि which notes, focus on the content. Okay, so thyroglossal cyst. So break the name. See, one another important thing I want to suggest you, that whenever you do not know anything and a new term comes in front of you on the screen in the exam hall, try to break that word. Like now, thyroglossal cyst, what does this stand for? Just break it and you will easily reach to the diagnosis, and if you connect the dots, you will easily reach to what the examiner is trying to ask. Thyroglossal cyst. Thyro means the thyroid. Okay, so there's a cyst involving thyroid. Glossal means tongue. Again, the tongue. So there's a cyst involving this thyroid and the tongue. Now the clinical feature, like most unique feature of this, is that moves with degglutination or moves up on tongue protrusion. Whenever you find this thing, one, the this finding moving with the degglutination and the thyroid, any cyst connected between the thyroid and the tongue, go with the thyroid. The age will be also like less. The age described, the presentation will be between 15 to 30 years, and it is a congenital condition and swelling in the anterior part of the neck, something like this. Okay, so two words are like more than enough in the question to come to the conclusion that the examiner is asking about the thyroglossal cyst. One, this moves with degglutination and the cyst. Okay, so this is the most common site, and like one liner have been asked on this, the most common site of this thyroglossal cyst. Then suprahyoid, then these are the other locations where you can find this cyst. Then the complications. See, this is also important because thyroglossal fistula will be occurring as a complication of this cyst, and it will not be present from the earlier. So complication, how does it occur? Whenever there's infection, infection will be forming the abscess, and when you do incision and drainage will be causing this thyroglossal fistula. So you need to be like very careful while dealing with this thyroglossal cyst, and this have been asked in the exam. Then it increases the risk of the papillary carcinoma, again an important point to remember. Then treatment of choice, cyst trunk operation, PYQ, repeated multiple times, and this image also repeated multiple times. So cyst trunk operation, I feel this is the favorite question of the examiners, and you, if you go and analyze, you can find this in each of the paper, this thyroglossal cyst. ठीक है, तो नोट डाउन कर लेना, 5 स्टार लिख लेना, कहीं पर भी नोट डाउन कर लेना, thyroglossal cyst मस्ट नोट टॉपिक. Then about the goiter, so a lot of things are there in the goiter. Let's not discuss all the things. We'll just discuss which all are important and which you must know. Okay, so two types hai, endemic and the retrosternal. So clinical feature, these are the clinical features which you must look at in the question. Like this is like mostly asymptomatic. If at all any symptoms are there, then there will be dyspnea and dysphagia and the hoarseness of the voice. So what does this show? An important finding is this dilated veins on the anterior neck wall, which is given with the name of the positive Pemberton sign. Remember this sign, and whenever this question is asked, then think in terms of the goiter. Okay, so this is like a piece of cake which will be given in the question. Okay, so these are the treatment options available. Thyroidectomy you will be doing using cervical incision or the radioisotopes. Radioisotopes again a must know topic, asked in integration with the pharma also. These are the two radioisotopes which will be using in relation with this thyroid. So what does 123 do? What does 131 do? Their half life and in which diseases or which particular uses questions are asked. Like 123 t half is 13 hours now, so it is less used in case of the diagnostic purposes, mostly in case of the radioactive scan, whereas this 131 used for the therapeutic purposes like the ablation. Okay, so these are must know which you must remember. Then goiter, diffuse goiter or nodular goiter, these are the types of the goiter. If it is diffuse, then that will be reversible with the iodine or the thyroxine, and if it is nodular, then it will be irreversible and there will be single nodule or multinodular, and image based questions have been asked on this nodular. Multinodular means, see, this is the face, this is the, so ऐसे करके this is the neck part, and here you can differentiate that like multiple nodule. If you palpate alive, you will come to know that there is a single nodule or multiple nodular, and in the image also you can clearly see that how many nodules are there, and you can come to know what is the answer, diffuse or nodular. Okay, so this is from the goiter which you must know. So before moving on, let's discuss about this Pemberton sign. What does this stands for? So this sign says that whenever you say the patient to raise their hands, you can see the congestion of the face due to compression of the uh, superior vena cava. As we see, compression will be causing this redness of the face everywhere, and this is the positive Pemberton sign. Image based questions have been also asked on this Pemberton sign. Okay, then so the other images which you must know is this radioactive iodine scan, which is also known as a thyroid scan. Okay, so in various diseases, various findings you can see. So this cold nodule, so whenever there is decreased uptake of nodule compared to the surrounding tissue, you can appreciate that in this area there is less uptake compared to the surrounding area, and in this case this is called as the cold nodule. And just opposite for the hot nodule, you can see here that this area is taking up more radioactive substance compared to the surrounding, so it is called as a hot nodule. Then in case of Graves disease, you can see this pyramidal lobe kind of a thing, and increase uptake in the whole gland whole gland, you can see increased uptake. Then in case of autonomous nodule means you can come to know by breaking the name, as I have already discussed. Nodule, so that means one nodule will be getting highlighted and another will be suppressed, because one nodule will be taking all the radioactive material. Then in case of thyroiditis, you cannot see it properly, because what happens in thyroiditis is the thyroid gland is damaged, and whenever there is damage, the cells will be not able to uptake the radioactive iodine. The cells will not take this radioactive material, and due to which there you can see this finding on the scan. And in case of toxic multinodular, you can see both multiple nodules with hot and cold. So hot and cold nodules are seen in case of this one. Okay, so this is about the radioactive iodine scans. Then moving on to the thyroidectomy. So these are the type of the thyroidectomy, and you need to know the procedure in which type what structures are removed and what structures are preserved, because questions have been asked on this. So total thyroidectomy, very easy, right? Total thyroidectomy, so complete removal of this thyroid gland, and these are the indications: malignant, and in case of benign, involving two lobes or multinodular goiter. In these cases we will be doing total. In case of hemi means removal of half, so half may one lobe will be removed along with the isthmus, and involving benign tumors involving one lobe. This is the indication for this hemithyroidectomy. Then subtotal, मतलब कि it is not total but totally thyroidectomy नहीं करेंगे, like near total के आसपास में we will be doing this thyroidectomy. So what does this say? What is the procedure for this? Procedure मतलब which all structures will be removed, leaving 3 to 4 grams superiorly. We will be removing all the thyroid, only 3 to 4 gram we will be leaving it and removing less rest of the thyroid. Done mainly in case of the mng, in case of elderly multinodular goiter, and these are the repeat PYQs. mng, what will be the management? Then Harley Daniel procedure, leaving 4 to 6 gram of the thyroid tissue, and near total means less than 1 gram. See, subtotal में 3 to 4 gram, near total में less than 1 gram, near the recurrent laryngeal nerve. So these are the types of the thyroidectomy. Then moving on to some benign diseases of the thyroid. So thyroglossal solitary thyroid nodule. So this is a benign, and one important thing which you must remember is this table. So FNSC is the most common investigation preferred in case of the thyroid diseases, but there are 3 diseases which where we do not do this FNSC. That is in case of the follicular carcinoma, renal thyroiditis, and the thyroid lymphoma. Okay, so you need to remember this point. Then so in case of this thyroid solitary thyroid nodule, the most common is this colloidal goiter, and the second most common is this follicular adenoma. First investigation to be done in case of any thyroid nodule is this TFT. Any thyroid disease the patient is coming, if in the clinical case it is given first investigation, then mark the answer as the TFT, and this is also a PYQ. So a question was asked on this one, that which of the following will be the first investigation you will be doing in case of solitary thyroid nodule. Then investigation of choice is the FNAC. Okay, so remember one thing, that FNAC investigation of choice for all the thyroid diseases except these 3. Then it will be like quite easier कि आपको ज़्यादा दिमाग नहीं लगाना पड़ेगा. Whenever you see other diseases other than this, you will be easily marking it as FNAC. Okay, so this is the chart how you will be reaching towards the treatment of this solitary thyroid nodule. So first you will do the FNAC. Based on the report you will be finalizing what treatment you need to do. Not that important for the FMGE. So if you have time and if you have read about it, well and good, but this is not that much important. Then Graves' disease, which is also known as diffuse toxic goiter. So this is the most common cause of the hyperthyroidism, asked in integration with the medicine as well as this surgery, physiology, everything. Okay, so Graves' disease or this hyper and hypothyroidism, you can expect one question. So most common cause of hyperthyroidism is this Graves' disease. So this is associated with the HLA-B8DR3. So mechanism is the autoimmune disease. So antibodies will be targeted against the TSH receptor, and this is important, LATS, long acting thyroid stimulator. So these are the clinical features which you can see: thyrotoxicosis in ophthalmos, pretibial myxedema, this is due to the gag accumulation, then acropathy and gynecomastia. These are the things from this Graves' disease which you must know, and this is what happens in the Graves' disease. So the antibody will be stimulating the thyroid hormone, and this thyroid hormone will be increasing the levels of this T3, T4. So there will be a negative feedback going to the brain, and TSH levels will be reduced. So what findings you can see? Laboratory findings: in case of hyperthyroidism, TSH will be reduced and T4, T3 will be increased. So you need to remember this one. Then the other findings associated is the hypervascularity, increased radioactive iodine uptake, as we have already discussed here. Image भी हमने discuss करा हुआ था. Then palpable thrill, audible bruit, and audible venous hump. So whenever you see these things in relation with the thyroid, things in terms of the Graves' disease in the case. Matlab in the question if these things are described along with some swelling in the thyroid, think in terms of the Graves' disease. Then There will be increase in the expression of the beta receptor, due to which there will be symptomatic activation, and we can see these findings in case of this emergency, and the treatment will be propranolol blocking this sympathetic symptoms: tachycardia, palpitation, excessive sweating, and the tremors. Okay, so this is the thing which you must remember from this Graves disease. The other are the eye signs, and in case of the eye signs are thyroid eye disease. So important from the ऑफ्थेल्मोलॉजी. सो यू नीड टू नो कि ऑफ्थेल्मो के इंटीग्रेशन में कैसे टाइप के क्वेश्चंस पूछ सकते हैं. देन एंटीबॉडीज positivity is seen, then we will be using this anti-thyroid drug. So anti-thyroid drug, I've like covered all the important things here which you must read from the pharma as well. क्योंकि here if you read it once now, you will recall it once again, so that you no need to like go again into the pharmacology. So the drugs, antithyroid drugs, methimazole, carbamazole, and the PTU, like repeatedly questions have been asked on this. PTU safe in case of pregnancy. Take a drug of choice in case of pregnancy is this PTU, safest drug, and this one can also be used. Carbimazole can also be used in case of this pregnancy. Okay, methimazole is the drug of choice, normally drug of choice. It is contraindicated, causes anomalies, teratogenic effect, and this side effect is hepatic failure. Okay, so these are the things which you must know from this antithyroid drug. The mechanism of action also: PTU converts acts by inhibiting the peripheral conversion. Okay, so this is an question asked: the mechanism of action and integration with the pharma. Then treatment of choice will be the total thyroidectomy, which is the best option, and then radioactive iodine ablation can also be done, and these are the indications for this RAI ablation. Okay, then moving on to the Hashimoto's thyroiditis, which is also known as the stromal lymphomatosa. Why is it called a stromal lymphomatosa? Because the thyroid tissue will be converting into the lymphoid tissue. Name itself is lymphomatosa. Okay? And this is associated with the risk of thyroid, lymphoma, and the papillary cancer, increase in the risk. So the things which you must remember from this Hashimoto is the antibody. So anti-TPO antibody, it causes what? Hypothyroidism. This one, Hashimoto thyroiditis, all the thyroiditis, these will be causing hypothyroidism. And one basic thing which you must know is the thyroiditis is the destruction of the thyroid tissue. So whenever there is destruction, T3 and T4 levels will be reduced, which will be causing hypothyroidism. There are various causes for this hypothyroidism: Hashimoto's thyroiditis, then subacute, then renal thyroiditis. We'll read about all those things one by one, and how you need to differentiate between the thyroiditis if at all a clinical case kind of question is asked. Okay, so first one is this antibody, which you must remember. And if given in the question, like it will be a piece of a cake. Yeah, anti-TPO antibody दिया गया है question में, then mark the answer as the Hashimoto thyroiditis. Blindly mark the answer as Hashimoto thyroiditis. What happens in this is that antibody, they will be destroying the cells, causing hypothyroidism. Permanent hypothyroidism will be occurring, and features of hypothyroidism can be seen. And now you might already know the features of this hypothyroidism. What all features will be described in the clinical case? Like there will be weight gain in the patient, then the patient will be having poor appetite, then cold intolerance will be there, cold intolerance will be seen, and fatigue can also be developed. Then fatigue can also be noted, that a patient feels weakness, and the extremities will be dry and cold, and delayed relaxation of the ankle jerk. So these are the things which are seen features of this hypothyroidism. So what we'll be doing treatment is levothyroxine, lifelong levothyroxine. This all is not that much needed. The mechanism of action, just remember anti-TPO, hypothyroidism, and this. On FNSC you can see the Hurtel cells, which are also called as the Ashkenazi cells. See, anti-TPO antibody, Hurtel cells, and hypothyroidism. Mark the answer as the Hashimoto's thyroiditis. So I'll give you three important findings which you can come to the diagnosis that it is Hashimoto. First one is the Hurtel cells, and you can remember with H, Hurtel, H for Hashimoto. Okay, then anti-TPO antibodies and hypothyroidism. Okay, three things given in combination, Hashimoto's is the answer. Okay, Then moving on to the next type of the thyroiditis. Again, in this also, as already discussed, the thyroiditis, destruction of the tissue, hypothyroidism hoga. But how you will differentiate it from the Hartle, and what other findings can be seen in this subacute? So the name itself says that it is subacute. This is also called as the decurrence, viral, or the granulomatosis, and the giant cell. You need to remember all these names because questions are asked. Once the question was asked like on viral, once asked on the granulomatosis, to confuse you guys. So you will be like reading this viral thyroiditis and you'll be like, "Arey, what is this? I've not read it once also." So the other terms also you need to know, because examiner can try to confuse you. You will be knowing the answer, but you'll get panic. To avoid that, look at the other terms also of the diseases. Okay, so the mechanism of action or the pathology associated with this is the virus. So viral uh, the infection, it will be causing upper respiratory tract infection. This will be causing granulomatous formation, and that granulomas will destroy the follicles and form giant cell. Okay, so now you can connect why these are called as viral granulomatosis or giant cell thyroiditis, and why it is called as subacute thyroiditis, because viral pathology, then granulomas formation will be seen and giant cells will be forming, due to which this is called with the other names also. These are the stages. What happens in this is that firstly there will be hyperthyroidism, because they are getting destroyed now. The cells are getting destroyed, due to which all the contents will be coming into the blood. First hyperthyroidism will be seen. Okay, then when all the content are relieved, and after the destruction of this T3 T4 in the blood, these levels will go back again to normal. And what happens is that when their normal level will be there, after some time, the thyroid, as they are destroyed, Allah cells are destroyed, so the T3 T4 cannot be released, due to which you can see a phase of hypothyroidism, and it will take time for the cells to again regenerate, and after the regeneration again it will be coming to the normal levels. Okay, so this is the, I think you're understanding what I want to say you, how this hypo and euthyroidism will be occurring. Okay, the first one will be that cells are destroyed, all the contents will leak, increasing the T3 T4. After that, this will be like getting destroyed, the T4 T3 T4, these will like undergo this degeneration and all, and um, it will become normal. But later, when all these also will be degenerated, then the thyroid tissue is not able to release more T3 and T4, so the levels will go down, and for the regeneration of the new cells it will take little bit time. Till then it will be hypothyroidism, and once the new cells are getting generated, it will be healing on its own. Then the levels will again come to normal. I hope you have understood what I want to explain in this. Okay, so like this is called a subacute isilier, because it is a condition where self-healing can occur. So this is the investigation which we will be doing. ESR will be increased, then radioactive iodine uptake will be decreased. Investigation of choice is the FNSC. You can see multinucleated giant cells. Okay. Then this is the treatment which we will be using. See, 90% already discussed that reduces spontaneously. Okay. If in the serious cases, if it does not reduce, then we will be doing with this NSAIDs or the steroids. So this was about the subacute. Riedl's thyroiditis, also called as invasive fibrous thyroiditis, a must-know topic, because frequently questions have been asked on this Riedl's thyroiditis. So the hint was, or a piece of cake which will be given in the case to reach you easily to the answer, are this fibrous tissue. Okay, so there will be formation of this fibrous tissue, and this is associated with the fibrosis around other organs also: periorbital, retroorbital, peritoneal, and sclerosing cholangitis. So whenever these things are described in the clinical case, think in terms of this Riedl's thyroiditis. Okay. Simple, just remember one thing: Riedl's thyroiditis means equal to the fibrous tissue. So fibrous tissue, thyroiditis already discussed now, damage of the cells. So why it is getting damaged? Due to the formation of the fibrous tissue. Fibrosis will be occurring, causing it to the damage. So fibrous, wherever you see, think in terms of this Riedl's thyroiditis. So features of hypothyroidism and hypoparathyroidism, and if the tumor increases in size, it will be causing this compression and these symptoms: dyspnea, dysphagia, and hoarseness. And on investigation of choice, hard and woody thyroid. Okay, so there's another finding with the name of hard and woody nose, which you can read in the ENT. Do not confuse it with this one कि hard and woody देख लिया तो जल्दी जल्दी में mark कर दिया. Read the terms. So the hard and woody nose, whenever is given in relation with the thyroid, answer will be the Riedel's thyroiditis. And investigation of choices is wedge-shaped excision biopsy asked multiple times. So this is a repeat question. Like they'll describe all the things about the Riedel's thyroiditis and they'll ask what is the investigation of choice, the treatment of choice. Both is same. Then so as it is a hypothyroidism, so you need to give lifetime levothyroxine supplements. Okay. Then this was a one-liner asked that most common thyroid cancer, matlab thyroid cancer, it is the most common malignancy of the endocrine system. The most common endocrine malignancy is thyroid malignancy. Oh, these were the things which you must know from this Riedel's thyroiditis. So moving on to the malignancy of the thyroid. One question is a sure shot. You can expect one question from this, either from this papillary or medullary, the investigation of choice, diagnosis, कुछ भी question आ सकता है. So be prepared for this thyroid malignancy. So a simple table, and in this all the important things have been discussed. So one table, you mug up this table and all the thyroid related questions are solved in a single table. So this is not that important. The first table, only important thing is this one. The marker for the medullary is the increased calcitonin, and if you are repeater, you might already able to recall these things, that parafollicular C cells arises from parafollicular C cells and calcitonin is the marker. Because this is quite famous PYQ about this medullary thyroid cancer. Then papillary occurs in the iodine sufficient areas. So orphan NEI nuclei image based question. This is the image orphan NEI. So the nuclei appears to be like the eye of the orphan NI, which is a cartoon character. Okay. So orphan NEI nuclei to image we have seen. Now other important things, some of bodies will be described in relation to it. These are not described yet and no need to remember that also. Just remember the submoma bodies and orphan NEI nuclei. And one important thing, submoma bodies, papillary, submoma bodies are most commonly seen with the papillary cancer, papillary of the ovary, then of the thyroid, and all the papillary cancer submoma bodies can be seen. Then central midline swelling and lateral aberrant thyroid. So this can be described that central midline swelling is given in the clinical case. So spread is through the lymphatics and most common site is the lung. Investigation of choice for all the thyroid diseases already discussed, it is the FNAC, but there are 3 exceptions. Remember those exceptions. Follicular cancer, because using this FNAC we will not be able to differentiate between the vascularity. Okay, so follicular thyroiditis and follicular cancer, we will not be able to differentiate between them, due to which for this the investigation of choice is the biopsy. Okay, so already discussed ki biopsy kyun hai, so note it down in your notes that biopsy, why it is investigation of choice. For rest of conditions it is the FNAC. Okay, then follicular cancer, what you need to remember, this mutations associated with this one, because this can act as a piece of a cake in the clinical case. So देखो बाकी कोई भी mutations associated से नहीं है, this one is associated with these mutations. So remember these mutations and you are reach to half of the way done ki you will be coming to a conclusion that which thyroid is the examiner trying to ask. Then sudden increase in the swelling and no pain and compression can be described in the clinical cases. So hematogenous spread and bones are the most commonly involved. Then this is the treatment. We will be doing this total thyroidectomy in case of this follicular. Then medullary parafollicular C cells arises from parafollicular C cells, repeat topic asked multiple times, and this also repeat topic asked multiple times, calcitonin. So the calcium levels will be normal and 2 types, sporadic and the familial. Then anterior midline anterior neck swelling and history of diarrhea can be seen and amyloid stroma present. So these 2 things can be described in the clinical case. Then the spread is the lymphatic spread as well as the hematogenous. So both lymphatic as well as the hematogenous, and liver is the most common site. This FNAC investigation of choice, and this one is the treatment. Total thyroidectomy plus central group lymph node removal if they are involved, with ipsilateral MRND with or without bilateral. Matlab ipsilateral or bilateral based on the structures involved. Okay, so medullary cancer. Then anaplastic cancer, which is the rare disease, 7 to 8 decade. इन्वॉल्व इन द सेकेंड टू 8 डिग्री, मतलब कि जो 80 ईयर्स होंगे, 80 ईयर्स वाले में उनको उनके में ये दिखता है. सो दैट्स वाई इट इज़ द रेयर. सो दैट बी सडन इंक्रीज इन द साइज ऑफ द स्वेलिंग, pain and compression is present. So direct invasion can be seen and lungs are involved. FNAC is the investigation of choice, and these are the two treatment options. So whenever you see this thyroid cancer in an elderly, mark the answer as the anaplastic, because the examiner is asking about the anaplastic, and this is the order. Most common is the papillary, second most common follicular, medullary, and then the anaplastic. And already discussed which points you must remember. So these are also the other things which questions are asked. So which all features factors will be increasing the risk of the papillary cancer? Low dose radiation exposure, Hashimoto thyroiditis, and thyroglossal cyst. All these three things are a risk for papillary cancer. Whereas papillary and the follicular, they are also well differentiated cancer. So these can be described in the clinical case just to make the clinical case lengthy and to confuse you. Okay, but always in the clinical case try to find the piece of a cake. So like the Hurtle cells, then the marker, then the mutations associated, the swelling, where it is present, how it is present, and all those things. Then speaking about the thyroid lymphoma, this is not that important, but as we are discussing all the important things related to the thyroid, so thought of discussing this one also. And like questions are like not asked that frequently on this, so this is a like rare topic which from which questions have been come. So the most common type is this non-Hodgkin lymphoma. Then risk factor are the Hashimoto's thyroiditis, and this one chronic lymphocytic thyroiditis are the risk factor for thyroid lymphoma. So these are the clinical features which will be described in the case, and investigation of choice is the biopsy, and this one is the treatment modality. Okay, so already discussed that FNAC done in all except three Riedl's thyroiditis, follicular cancer, and this thyroid lymphoma. In this we will be using the biopsy. Then this is the thyroidectomy. So questions have been asked on the thyroidectomy on this hemorrhage. The most common is the hemorrhage, and it can cause tension hematoma. So this one was a PYQ. Then these are the other complications which will be occurring in case of thyroidectomy. Respiratory obstruction can occur, then nerve injuries. So this is also a question asked, like they can describe a patient was being had so and so thyroid symptoms, मतलब कि thyroid की कोई भी condition दे देंगे, and they'll ask that during the operation this a structure was injured, or post operative the patient presents with so and so symptoms, which of the following nerve is injured. So based on the clinical symptoms described in the case, you need to mark which one is involved, and if it is like most commonly involved, then it is the ENL which will be most commonly injured. Parathyroid insufficiency can also occur because we will be accidentally removing sometimes the parathyroid hormone, and due to which parathyroid insufficiency can occur. Then thyroid insufficiency and thyrotoxicosis, thyrotoxic crisis, and the questions are asked on the prevention. How will you prevent it? By giving this antithyroid drugs prophylactically before the surgery. And why does this occur? Because when you do the incision of the thyroid gland, some hormones which are like present, not like present, but some hormones they tend to leak into the blood vessel, causing this thyrotoxicosis. Isliye prophylactically we will be giving this antithyroid hormones, and also you need to keep this other prophylactic drugs ready. Okay, so this thyroidectomy, how it is done? The position is the rose or the barking dog position. Head is extended and 30-degree head, and this one is the incision given. So the name is the Cockers, the surgeon who had done this incision, and this incision is given on their name, Cocker's transverse cervical collar incision. Question can be asked on this. Then these are the structures which are pierced in case of this thyroidectomy. Middle thyroid vein, okay, this is the sequence, like we need to avoid injury to these things, and whenever there is injury, then these can be causing the symptoms. These are the symptoms the complications which it can be causing. If middle thyroid vein is involved, then it can cause embolism. Superior thyroid vessel external branch, of the SNL nerve, superior laryngeal nerve, inferior thyroid vessel causes parathyroid ischemia because this is the vessel which is supplying the parathyroid gland. Then these are the nerve injuries which should be occurring in case of thyroidectomy. Okay, so these were the important things from the thyroid which you must know. So we have discussed about the cancer, then also the benign tumors and the most commonly asked questions. Okay, so like in 30 minutes we have discussed all the important things. So do watch the part 1 video on the breast and wait for the next video in which I'll be either discussing about the liver or maybe about the GIT or esophagus. Okay, so join the Telegram channel for more amazing stuff related to the FMG. The link is given in the description box, and stay tuned for more amazing videos. If you're new to GrowMed, subscribe to GrowMed. And also another important thing is for more amazing videos to make your preparation more effective, join the membership. So you can see various plans on the membership. So for more useful videos, join the membership. Okay, so thank you so much for watching this video, guys. For the PDF, join the Telegram channel. I am Dr. Padmini, your mentor for the FMGE. Thank you so much once again. Bye bye.